Welcome everyone, and many thanks for taking the time to join this webinar today. My name's Jean Ledger and I'm a research fellow from the Department of Applied Health Research at University College London, and I'm really delighted to be hosting this session today and that you've decided to join us. I'm co-hosting this session with Professor Henry Potts from the Institute of Health Informatics at UCL, and we have a really fantastic lineup of speakers today ready to discuss how to ensure quality evidence generation for data-driven technologies. Just as a reminder for anyone who's joining these webinars, that it's part of a series exploring evidence generation in digital health, and it's sponsored by a knowledge exchange fund from University College London and delivered in partnership with DigitalHealth.London, MedCity and the Health Innovation Network. So the format of the webinar is that we'll have a panel discussion with our speakers for around 30 to 40 minutes, and then we're going to open up for questions from the audience. So this is just a quick reminder to put any questions or comments in the online chat, because that's being moderated by Henry, and we really want to hear from you today. You can also engage with the series and this webinar using the Twitter hashtag, which is #EvaluateDigiHealth. So now to our speakers and who we have today. We have Carmelo Velado, who is Senior Research Fellow at Sensign Health, and he's a visiting academic at the Department of Engineering at the University of Oxford. We have Jess Morley, who's policy lead at the Oxford Data Lab, and she's also doing her PhD at the Internet Institute at the University of Oxford. And Cassandra Kapathakis, who is head of AI strategy at the NHS AI Lab at NHSX. So a warm welcome to our speakers, and many thanks for joining us today. Cass, if I could turn to you, particularly for those who are watching and may not be familiar with the UK's NHSX, could you tell us a bit about the organisation and where you work, please, and what you're involved with?
Great, thank you. And thanks everyone for joining us today. So NHSX is a joint unit between the Department of Health and NHS England Improvement. And essentially what we're doing is leading the digital strategy for the NHS and social care, supporting clinical teams in priority areas across the NHS. We're also the digital transformation arm of NHS England. So we're helping make that shift towards a digitally enabled frontline services. And we did this during the pandemic, and we're continuing that work after, in this next phase. So NHSX's ambition, if you're not familiar with it, is to digitize, connect, and transform the health and social care system. And it's really about thinking how we can use digital services in an equitable way, in a sensible way, to make sure that the systems talk to each other and that we can connect the health and care system. So I work in the NHS AI Lab, which was set up about 18 months ago. And the mission that we have is to accelerate the development, adoption, and use of safe, effective, and ethical artificial intelligence technologies into health and care. It's a very big mission. And what we're really trying to do, from my perspective, is show that use case for artificial intelligence and to think about what are the enabling factors, what sits around bringing that into the health and care system. How can we make sure that the system is ready to bring in artificial intelligence and other emerging technologies? So my role within the lab is the head of artificial intelligence strategy. I'm currently leading the development of a national AI strategy for England, looking at the health and care system. We work quite closely with the Office for AI, who are developing a national AI strategy for the UK across all sectors. I've also got a personal interest in evaluation. So I previously worked at Public Health England, where I headed up the creation of evaluating digital health products, which helps teach teams how to evaluate the digital health product from the get-go. And I work in our international space. So I've done a lot of work with Global Digital Health Partnership, the World Health Organization, and I'm currently leading our work stream in the G7 looking at AI governance. So very pleased to join you here today.
Thank you, Cass, and that's a huge remit. So looking forward to hearing more about what you're working on today. If I can go over to Jess. Hi, it's really lovely to have you here. Can you tell us a bit more about what you're involved with and your interest in evaluating digital health technologies?
Sure. So thanks everyone for joining us this afternoon. So I am a researcher in the University of Oxford and I wear 2 different hats. I am employed in the Department of Primary Care Health Sciences where the Data Lab sits, and we build data science tools for analysis of primary care data. We have open prescribing, for example, and more recently we have Open Safely, which is the largest secure electronic health records analytics platform, through which we do analysis on behalf of NHS England on COVID. And the other half of me sits in the Oxford Internet Institute, where I am doing my PhD in designing an algorithmically enhanced NHS. Previously to this, I was in NHSX and set up the AI lab. So I suppose, or helped set it up anyway with the funding. And so I suppose my interest stems from that. And throughout all of my research, I am focused on translating between the technical and the policy, and how do we enable the better use of broader, safer use of data in the healthcare system.
Great, thanks, Jess. And is your PhD focusing on anything particularly you'd like to tell us about today, any particular angle?
So my PhD is about how do you deploy big data analysis in different levels of the healthcare system. So you can call it AI for the purpose of being simple, in different levels of the healthcare system. So primary care, secondary care, or community care, and what are the technical requirements, the ethical requirements, and the socio-cultural requirements that enable that to be successful.
Amazing, thanks very much. Kamala, you were formerly at the University of Oxford and now at Sensign Health. Maybe you could tell us a little bit about Sensign Health, when it was founded, and how you've got involved and what you're working on now.
Sure. Hi, everybody. So I'm Carmel. I'm an ex-academic at the University of Oxford. I joined Sensign Health 2 years ago, just after it was established in 2018. Sensign is a company that has a unique business model. Our mission is to basically improve health and create benefits for all involved in the healthcare industry, and that includes patients, it includes the clinicians, and also the other communities such as pharma and life sciences. And we do this by having two divisions. Effectively, we have a life science division, which takes care of combining clinical and data science expertise to develop machine learning technologies that then we apply to data that we source ethically from electronic patient records from our trust partners. We effectively act as a kind of docking station. We call it the docking station model between life science industry and the healthcare sector. And there's a mutual benefit there, because in that way, the insights that we are capable of generating through accessing this data then can benefit the life science industry, and on the other way, the value that we generate then flows back as a kind of revenues into the healthcare system as well. We're building up a data set of electronic patient record data, which are de-identified and anonymized, and to further develop the skills and the capabilities of this data, we are developing Sensight, which is a research and development platform that will accelerate the speed at which we can generate more insights from this data set, and we can and the speed at which we can process this data. There's another division in Sensign, which is the healthcare division, which instead is a little bit more healthcare focused on the healthcare systems, and the aim is to connect healthcare professionals with patients. And in that specific division, what we do is designing products that span a variety of applications, such as, for example, decision-making support, or remote patient monitoring, more recently diagnostic and prescribed digital therapeutics, all infused with AI capabilities, such as opportunity that could provide opportunities to improve the way we deliver care. All of these, in a way, in a context of obviously regulated medical devices that will obviously be delivered initially in the UK and the US market.
Thanks. Thank you very much, Camilo. I think because we're very interested in evidence generation for digital health, and particularly when we're in discussions about products that have an AI component, that the question of data and real world clinical implementation and validity comes up a lot. So it would be useful to explore with the three of you a bit about using clinical data for real world evaluations. And you've mentioned some models using data sets that are being tried out and developed. So if I might ask you, Jess, could you tell us a bit about Open Safely in particular, why that model's different, and what's that telling us about using big data safely for analysis and potentially for evaluating going forwards?
Yeah, sure. So I suppose I should start by saying at the moment we don't use it for evaluation. We rely on COPI notices for our information governance. So we can only do research that's related to COVID, but that's no means why we can't do things in the future. So Open Safely is effectively a software platform that creates a trusted research environment, which basically means that we have access to almost the entire population's records, so about 95% of the population's records. It's 95% because we have two instances. We have an instance inside TPP and an instance inside EMIS, which are providers of electronic health records for primary care. And they cover about 95% of the practices in the country. There's about 5% that sit with smaller providers. And what we do is the data stays where it is. So it never leaves the GP practice. It stays where it is for business as usual. We run the software platform over the top, which basically means that we send the code to the data rather than bringing the data to us. All analytic code is automatically made available in public. So you can see who's accessed the data for what purpose, but also, and this is where we start having implications for things like evaluation, it means that you can reuse the analytic code. So anyone can take it and use it for a different purpose. So you might be able to say, right, well, we've tested in this cohort of patients. Now let's take the exact same method. Say we were doing a risk prediction tool. Let's take the exact same method and see if it also works in this patient data set, because that code is all available and openly, readily available for other people. I suppose as well, the aspect that's relevant for real world evaluation is that normally, if you're working on a model where GP data flows via extraction, so I request from this GP practice, I want a bunch of data that looks at patients this, and this, that gets signed off by whichever ethics approval board, and then you get sent the data. That takes quite a long time. So you might be talking about 6 months, and we've even heard of cases of 2 years plus of it being slightly out of date. And that is a problem if you're trying to look at evaluation in real time. Whereas with Open Safely, because the data stays where it is at all times, we have a maximum of a 1 week delay. So you can see you're getting as close to near real time without being in an actual clinical setting as is currently possible. And that has significant implications for trying to test things if you are looking at evaluation. So I suppose the things that make it different, it's safer because the data doesn't move. We send the code to the data rather than bring the data to us. This much higher security means that we have a much higher volume of data, which allows us to do real world clinical trials in the data. So you can do cohort analysis in the data, this A versus B. And then the final bit is that because it's also safe and not moving, we can do it in almost close to real time.
Yeah, so it's primary care data, isn't it?
Primary care is the basis, but we do link to other data depending on specific projects. So for example, we did a project last year on factors associated with negative outcomes from COVID in hospital. In order to work out what outcome people are having, you have to link the primary care data to secondary care data, to ICU data, and to death data. Otherwise, you don't know. So, for example, death data is recorded far faster by the Office for National Statistics than it would ever end up in your primary care medical record.
But, I mean, the principle there is about the data not leaving the systems, which is really interesting one for us to keep in mind when we're thinking about research and evaluation. Carmelo, you've been involved in the evaluation of digital health interventions, and you bridging the worlds of academia and industry and also NHS partnerships. I just wondered, if you had any principles or lessons about how you're using data, and particularly sensitive big data, to evaluate digital health products and solutions, and maybe lessons for our audience that you might have.
Yeah, so obviously, and within background in academia and industry, the type of access to data is slightly different in terms of academics. Come from the background of the University of Oxford, and with the very strong relationship they have with the Oxford University Health Trust there, and so the access to data was a bit more facilitated in a way. Each innovation, I think, is a little bit different, and so it will be challenging to generalize a kind of recipe that works for everyone. But I think in general, after seeing both the academic and the industry side of dealing with data, I'd say possibly three main lessons. The thing is, healthcare systems, the NHS, or even in the US, are quite willing to collaborate with industry and researchers. And I think that the key point there is that the benefits for the patients and the benefits for the society as a whole, and the healthcare system as a whole, have to be very clear and very centered to that kind of collaboration. And it's certainly the case for Sensign Health. Then obviously data protection, privacy, we heard already Jess mentioning it. The security of the data is extremely important, especially nowadays in the current status of things. And then the third one is health is quite complex. We're talking about evaluation, and so thinking that we could just access the data and evaluate how something is doing, and innovation is doing, or that we will have kind of the key to solution of all problems is kind of very simplistic as a view. And so health is a complex matter, especially the difference between theoretical and practical applications of these innovations makes it so that it's quite important to have a kind of deep understanding of the problems we are trying to solve, deep understanding of the environment that these solutions are going to be implemented. Sensign does all of these three, I would say. In terms of collaborating with the healthcare systems, we do it through strategic research agreements. So we have effectively these agreements between us and all of the NHS trusts that collaborate with us, and they want to participate. These agreements are kind of very clear. They establish a very clear base under which we can then share data safely and securely. We can do it with the right information governance in place that allows both the trust to trust Sensign when they share the data with us. At the same time, also Sensign to be clear that we are doing all things transparently and safely, because effectively it's a business, and it's going to be something very important. The data we receive are de-identified and anonymized. This de-identification and anonymization is managed through the highest standards. And at the same time, whenever we initiate a project with, for example, a life science customer, which involves trusts from the NHS, the clear the clear benefits to patient has to be kind of center, and it's a process that is very, very common in research in terms of ethics and in terms of understanding the clear research question, and Sensign has that. And it's obviously quite welcomed by the NHS Trust that then are very happy to cooperate with us. All of these, I would say, it's basically then set in a scenario where regulations such as HIPAA in the US, GDPR in the EU, and UK GDPR now are giving us a very nice and clear framework to work around, and provides a lot of guidance. Is certainly quite large corpus, but it provides a lot of details and guidance to companies that might want to jump into this space.
Thank you. So what I'm hearing there is it's a very rigorous and academic approach you're taking within industry, but it's fundamentally a partnership model with NHS organisations as well about the use of data.
Yeah.
That's really helpful. So Cassandra, you're at NHSX and focusing on a very difficult space of regulating AI. I think it'd be really useful to hear some of the latest developments. And I mean, what are you thinking about when it comes to the kind of processes and infrastructure needed for evaluating AI technologies, which are so data driven?
Absolutely. That's a really chunky question. So I will do what I can to sort of get through it. So we're doing a few things in the NHS AI lab, and we're very keen to think about practical approaches to real world evaluation of AI products, and also to learn about how you can do those evaluations and implement them easily, and what sort of relationships need to be in place to make those successful as well. And what are the skill sets required in order to deliver those evaluations, both from the technology team, the sites that you work with, and the evaluators themselves, because it is quite a nascent field. So everyone's learning as we go at this stage. So one of the programs within the AI lab is the Artificial Intelligence in Health and Care Award. And it's 140 million we're making available over 4 years to accelerate the testing and evaluation of these technologies that meet the aims out in the NHS long-term plan. And I think we've just announced round two award winners on this. What I find really exciting about this award is we've actually, for later phase technologies, which we call phase 4 award winners, where we're ready to deploy them at multiple sites and scale them up, we're commissioning independent evaluations, and we've already kicked off a handful of those. So essentially, we're deploying these technologies in real world settings, and we're bringing in independent evaluators to understand evidence gaps and also to assess the technologies across 8 domains. So that's accuracy, effectiveness, safety, value, fit with site, how it was implemented, feasibility to scale up, and sustainability to scale up. And all of this is done with a range of academics, NICE, MHRA. So part of this, when we set up these evaluations, and I sat on the evaluation advisory group and set these up, we started aligned to the NICE evidence standard framework for digital health technologies. And we're thinking, if you applied that to AI and technologies, what would that look like? And where do we go with these evaluations? So that's led us down a pathway for some of these technologies where we've got a mixture of technologies that mostly fit into tier 3B on NICE evidence standards before the refresh. And the evaluation designs include prospective, retrospective studies, as well as RCTs that we're running over 12 to 36 months across multiple sites. Now, what was quite interesting about all of this is the NICE evidence standards framework and its current guise fit for purpose for artificial intelligence technologies? I think that's an outstanding question, and one that we're now actually diving into with NICE. So we've just funded NICE to do an empirical review to update those evidence standards framework to make sure it incorporates algorithmic technologies. So they've just commenced an exercise to source an academic partner to help them with that. And I think that we've sort of shed a light on whether the same standard of evidence for digital health technologies is appropriate for artificial intelligence technologies. Alongside this, Jess and I have actually just about halfway through a project where we've gone back, was it to 1970, Jess, with the literature, looking at over the past 40 years, what is the standard of evaluation practice for algorithmic technologies, decision-based systems? And how do you do this in a way where you accept that until you put them into the wild, you don't really know how they're going to function? And how do you blend that with the move towards user-centered design, which I'm a staunch supporter of? So what is a practical evaluation approach? So we've just created a framework that will feed into the NICE work as well, that is starting to influence the work that we're doing through the AI awards. And we'll hopefully have something that we can share publicly in the next few months. So all of this is what I say is we are trialing, we're experimenting with these evaluation techniques, and we're going to be sharing these learnings back. So we'll be playing back what worked from the site point of view, what worked from the capability point of view, what infrastructure is needed, just as Jess described, how we got the data to compare the technology to what was done previously, also the impact of COVID and how you can mitigate that when you're looking at evaluating AI technologies. I think that answers your question.
It's really helpful. And one of our first webinars for people watching was we talked about early regulation across the US and Germany and the UK, and mentioned the NICE evidence standards framework. And obviously that wasn't originally intended for AI, was it? So obviously now you've moved things on to see if it can be extended and may fit for purpose. So
yeah, absolutely.
It's an interesting question, and I'll throw this open to all of you, just about data quality. I don't know what you're hearing, Cass, in your work, but for example, we've seen recent papers, and they basically, do a systematic review, and they look at a lot of machine learning tools, some of which have been deployed during COVID-19, and found that they weren't reproducible, and that data was biased in terms of the participants. I don't know if between the three of you as experts, if you've got any views on data quality, which seems absolutely integral to AI evaluation. Maybe Cass, you could start with that one.
Yeah, and we did discuss this a little bit ago, where while they do shed light on the data quality issues, what they would say is what we've been able to see through the work we've done on machine learning in the COVID-19 pandemic, and what we've done through the National COVID Chest Imaging Database in the lab, for example, is that we've opened up the acceptability of using these technologies, and actually open up the conversation more to say the data standards don't exist. The data quality isn't there. We want to do this. We know it's valuable. We've sort of got a proof of concept, but how do we bring everyone to the table to have those conversations about what are those data points you need? What is the quality of data? And other countries that I speak with on this, a lot of their data quality is actually compromised because they can't get access to certain hospital data because of different information governance arrangements, different trust in sharing that data. And then again, if you just accept that, you're not going to get an algorithm that's worth using. So how do you bring that together and make people, what does need to be in place to share that data, and to share it in an ethical way, but also to share it in a way where people understand the value of having shared their data with you.
And a big debate over here in the UK at the moment. And Jess, I mean, that issue around missing data, compromised data, and data quality, do you have any particular thoughts on that?
Yeah, I mean, I suppose the thing we should always remember is that health data is effectively an administrative data set. It is generated as part of the business as usual workflow, and it was never really designed with the intention of, oh, we're going to go and use this to build big predictive models off the top of it. It's effectively, if you're talking about GP records, they're very, very detailed, but they are effectively an aid memoir for your doctor. Right, this person has had this diagnosis, this person is allergic to this person is taking this medication. And to take all of that and effectively assume that what is collected during a maybe 10-minute interaction with a person ad hoc now and then is a perfect representation of who that person is in a health manner is quite unrealistic. Now, there are a couple of things we can do with that. Like, generally, the more that records are used, the better the quality gets, because people notice mistakes. So to give some examples from Open Safely, we were looking at vaccine uptake a while ago, and we found some very odd results where it was throwing back a whole bunch of men in their 70s who were apparently pregnant. Clearly, men in their 70s are not pregnant, but they had been coded, as in the SNOMED code, the diagnostic code was for a bad knee, but it was actually very similar to a code for fetal problem, and therefore they were throwing themselves up as pregnant. Similarly, to stick with the pregnant example, people are very often coded as being pregnant and very often not coded as having had the baby. The way to work that out is to link with the child's new record or with the birth record and say that that baby has been born, which means we end up often with women who have been pregnant for plus 2-3 years. And if we were to take the example from, now this is where we sort of start to get into evaluation, if you were to take the example of shielding, the shielding list for COVID was developed in part by QCOVID, which is a research group in Oxford actually, but separate to mine, where they had developed a risk prediction model effectively to say, what is your likely result of having a negative outcome to COVID? And these are the people who should shield. But that model wasn't validated in an external data set. It was modeled on a subset of general practice data. And then once it went live, it of course showed up that there were a number of problems with it. For example, lots of women were being told, or people who had once had a diagnosis of gestational diabetes, that they should shield, and people were very confused because they're like, oh, I haven't been pregnant for like 5 years, what's going on now? The way we could get around those types of issues is, as I said, providing broader access to the data in a safe way so that quality issues can be fixed. by sharing the underlying code of the model that you have developed so that other people can validate it, and then by providing secure access to population level data sets. Where we often hit problems is where you've got subsets of the data. So I don't necessarily know whether this subset is proportionally representational of the population. There are some more technical things that you can do in the middle. So I'm sure Camelo will talk about this, but one of the things that we do with OpenSafely, for example, is rely very heavily on synthetic data. So you press a button and it will spin up a modeled version of the underlying data. So you're never touching the real data, but I can then test whether or not my study definition, so how I've defined a person that I'm looking for in my model, is actually the type of people I'm looking for before that even touches the data, which allows you to be much clearer about what you're doing. It allows you to do pre-study evaluation, and it also has data ethics benefits because you aren't doing sort of exploratory research on people's raw records.
That's really helpful, Jess. I mean, I think that's the thing that's coming up in some of the more critical papers around machine learning, is about these data sets not being externally validated, and very limited data. Carmelo, I mean, before we get on to thinking about SMEs and companies and actually how they navigate this really complex world, do you have any thoughts on data, particularly as someone who's used it to evaluate digital products, and ones that, and solutions you want to get implemented into the NHS?
Yeah, absolutely. I mean, and Jess touches very common and important points in the world of ML, AI, and analysis of data in general. Discussing things such as the odd miscoding, or so kind of errors effectively, or imprecisions of reporting some of the values in the electronic health records, up to the other issues, which is missing data. Where you could have also missing data at random, not at random. And so all of this is, it touches on areas that have been quite explored in the machine learning research, academic research, and also applied. And as Jess points out as well, is generally what helps you is having access to larger data sets. This is one way of solving it, obviously, and we do it, a SenseLine on the back, obviously, of the very large data set that we have managed to have access to through the partnerships we have. That obviously is really important on the evaluation side as well. And because it can help you remove bias, it can help you, or it can help you assess if there's any bias on your models, on the models prior to delivery. And I would say the regulators are aware of this, a bit more probably in the US, but also in the UK and in Europe. And there are requirements. There are requirements of validity, both clinical and technical validity of the solutions that you want to certify as medical devices. And they need to be, and this evidence needs to be presented. So obviously is an aspect that is going to be taken into account. The other aspect is obviously having access to clinical know-how, and that is either through your own internal clinical team, if you're a company and you have one, or through partnerships, or through collaborations with academic institutions that might have access to that. Because most of the things that Jessica has mentioned, for example, in terms of identifying the actual, SNOMED codes for pregnant men, it is more evident when you end up with collaborating with clinicians. So having people that are in the ML domain, yes, expert in the ML domain, but collaborating hand in hand with clinicians at the same time, because there's a lot of hidden patterns that then emerge, and that might be due to some bias in your own data set, and you want to kind of have the clinician in the loop to debug, to investigate a bit further the reasons why of a specific behavior.
That's really helpful. So, I'm hearing a lot about NHS partnerships, clinical partnerships, and a lot of pre-testing of your data set before you even launch into full research or evaluations. Many people engaging with our webinars have been SMEs. They may have solutions that are going to capture a lot of data, generate their own data, but they may not know where to start on their evidence journey, and they don't necessarily have the money or the infrastructure and the access that many of the big universities and bigger companies have. So, I mean, Cass, there is an advisory service being set up, and when thinking about smaller SMEs, I mean, where can they begin? What would you signpost them to for thinking about evaluating their products?
Absolutely. So just to touch on the advisory service you just mentioned, in case people aren't aware. So we're in the process of creating a multi-agency advice service, which is a collaborative project between NICE, MHRA, CQC, and HRA. And essentially what we're trying to provide is a virtual one-stop shop, though I hate saying that now that I've said it, of information, advice, and guidance to stakeholders and SMEs and people who want to work in this space. And it's really about recognizing that it is quite difficult to navigate the health and care system and to navigate that regulatory system, and also just to find other people like yourselves that you can work with and learn from. So that is in the process of being set up. Where I say people should start, if they've already got products or they're already on that development journey, it's definitely worth deferring to the NICE evidence standards framework and to start understanding what is that level of evidence that you have to show or that you should show, because it's best practice to get these technologies into the system. Well, I would, coming back to what I was doing at Public Health England, which Henry is very intimately involved with at the moment, is, in my experience, a lot of people are just missing the basics when it comes to evidence generation. And if you're new to this, you probably haven't done it before. So when thinking about developing a digital product, it's about understanding what you're trying to achieve, understand the outcomes you want to influence, create a logic model, start, learning about those tools, start speaking to academics, connecting with other people in the system. Within the AI space, we've actually set up a virtual hub, which is a really good place to connect with academics working in this space or other developers, and again, to share that learning. So you can learn a lot about the basics of evaluating digital health products, and those basics, they retain across whether you're doing artificial intelligence technologies to a basic app through the Public Health England Evaluating Digital Health Products service that we've created.
Thanks, Cass. And Jess, you've done quite a lot of work looking at apps and the quality of evidence underpinning them. Do you have any guidance for companies? Again, they may not have the massive resources, but they need to start somewhere. You must have seen examples of where it's done well, and maybe you could have some tips or suggestions.
There are some examples of apps that do it really well. I'm going to sound super biased because it's an app that came from Oxford, but it's actually just a good app. It's the Sleepio app. Is a really good example of where they have done proper evaluation using clinical trials or a randomized clinical trial to show the impact of what it is it's doing. I suppose if I was going to be super pragmatic and not be the pedantic sort of academic ethicist, one thing I would say is think of it as just an extended version of user testing. So we've got to start building these things into like a normal workflow. So is my app doing what I said it actually does? And is it solving the problem for my user group that I actually think they want solved? Those are two very, very basic questions, which are actually just part of product design. They're not necessarily separate in a separate thing sitting off on the side of evidence evaluation. And then I would say, think of it the other way, it's also about marketing claims. So when we've seen things fall foul of this before is with the Natural Cycles app, which was claiming to prevent pregnancy, and then loads of women got pregnant and were like, actually, this was a false claim. So that's a marketing problem. So don't make claims about things that you cannot verifiably say are true. That's the biggest problem with apps on the App Store at the moment, is they often claim to be interventional. And then you go and look and you're like, well, you cannot possibly be doing what you say you're doing, because if you were, you would be the digital equivalent of God. So you've kind of got to find that balance. Don't overclaim, think of it as a marketing thing, and then think of it as your general part of user testing. And as you scale up, then start thinking about what the opportunities are for proper testing.
Thanks, Jess. And before we go into questions and I hand over to Henry, Camilla, you've been involved in evaluating gestational diabetes intervention and various things. I mean, very early on that evidence generation journey, where did you begin? I mean, you're working in the world of very large data sets now, but that's not always the case. Maybe you could tell us a little bit about what you did for that product.
Absolutely, yeah. So it's the GDM Health Hub, effectively, that is now under the in the portfolio of Sensign. It started as a research project from the University of Oxford, but initially we had, as a researchers, kind of struggled to expand further from the research project itself. And we found a lot of help was provided at that time when we have decided with the team to effectively try and expand a little bit outside the remits of the clinical trial that we were doing, to expand to other trusts. And we found lots of help from the academic and science networks. For example, we have a very active one in Oxford, which provided lots of information, know-how, to a group of researchers that was including as well, obviously, doctors, clinicians, nurses, patients, but in a way lacked a little bit that kind of know-how I was discussing before, the difference between theoretical clinical knowledge and practical clinical knowledge, and the understanding of how the NHS works effectively. Besides that, obviously, then we have found a perfect partner in Sensign that managed to scale up the solution to more than 46 trusts nowadays that are using the app. But I would say for SMEs and groups that are starting right now, an interesting the interesting bit is finding the network, right? The network of clinicians, the network of experts of the sector that could help you answering some of the questions that you don't know. And I would say probably apart from the AHSNs in the UK, you can find help from accelerators such as DigitalHealth.London, I would say, or even local communities. In Oxford, we have The Hill, which is a group, self-organized groups of individuals that are expert of the sector of digital health, and then they meet at the Oxford University Hospital Trust, and they provided kind of environment where you have clinicians coming in, intensivists, nurses, patients, and innovators, and it creates an ecosystem that that is self-sustaining because it helps everybody building and maintaining these solutions in the world. And yeah, so that's what helped us a lot. Yeah.
I think we keep hearing in these webinars over time that partnership, building these communities of interest is really important, but also it can be quite lonely for a while when you're starting out, particularly for a smaller SME. Trying to navigate it and building those networks is really tricky. I'm going to hand over to Henry Potts. I don't know if there's been any questions on the chat, Henry, but you might have some reflections or questions for the panel today.
Hello, everyone. We've got some questions coming forward. So we've had a question around the cost of randomized controlled trials as being a significant barrier to entry, and therefore are those the right tools for the evaluation of these products? But I'd also like to open up that question to the question of who should pay for a trial in this context. Who should pay to make data available? Who should data be made available to in terms of public bodies or commercial bodies?
Yeah, I can jump in first. I was just typing a reply to the chat, and then Henry has asked, so I'll speak my reply. So on the topic of RCTs, I don't think they are the solution all the time. For one thing, there are problems with RCTs. They aren't based in the real world. They are taking place purely in a lab-based environment, and that isn't what necessarily is going to happen, particularly when we were talking about digital projects or products, because they're almost always consumer facing as opposed to being deployed necessarily by a clinician. And so that parallel is not necessarily the same that you would get with a sort of RCT if you were using a drug. I also think we've got to be very proportionate to risk. If I am talking about an app that is simply telling me that I should drink water every couple of hours, then I'm not sure we really should be saying, right, you absolutely have to spend 500k on doing a randomized control trial. If you are doing something that is significantly more risky, then I think we probably should be looking at a higher level of evidence standards, and that's how the NICE evidence standards work anyway. I also think you've got to be aware of the fact that RCTs work if we are doing a baseline comparison. So RCTs work if I'm comparing A with B. Often with digital products, we're not necessarily comparing against that baseline. So one of the things I hear a lot with AI or digital things is, oh, it will beat the clinician. Like, how in the hell do we know? We don't have a baseline performance of clinicians. We might have an average, but we definitely don't have this is how something is performing in all circumstances. For example, triaging in A&E, we don't necessarily know how well that's working all the time. And we know that potentially algorithms could outperform. But I think if you are making claims about interventions, so this can achieve X, this specific thing can achieve this specific outcome, that point I do think you need to be looking at whether or not you do a randomized control trial, because you are making a definitive claim, and the potential harm that can come of that is significant. I think if you're talking about other types of things like clinical decision support software, there should absolutely be validation studies, and you should do looking at things like multi-site testing and the difference between different providers. But whether or not you call that a randomized controlled trial, I think is debatable, because you aren't doing it in a lab setting. And the other aspect to consider is we want to test the entire pathway. Not just the function of the thing in and of itself. We're not necessarily just giving a person a new drug. You are actually potentially transforming the way the entire care pathway is delivered. And then to Henry's question, in terms of cost, I think it depends really on where the pressure is coming from. So I don't think it's necessarily fair if you suddenly change the ground. So if you suddenly move the regulation goalpost and say, this is now the standard that absolutely has to happen, for that cost to immediately be put onto SMEs or to researchers. We know lots of digital products come out of spin-outs, and I think there's an argument to be made that some of that, if you are shifting the goalpost from a regulatory perspective, should at least in the initial period of time be swallowed or be at least made available by central government. Whilst people adjust to that. I think once it becomes the standard or the norm, at that point, you probably should be factoring it into your baseline from the beginning. And I think the justification for it being centrally funded lessens over time. Yeah.
If I can jump in just to stress a bit more what Jess said as well, is I fully agree with what she's saying, and the evidence required at the moment by regulatory bodies varies substantially according to the level of risk and the level of classification that a medical device will reach at the end. And so, for example, especially in the domain of ML and AI, we already see FDA has already published their thinking around the validation process of what they call software as a medical device, SAMD, and we see more clarity coming from UK bodies and European bodies. But I would say that it's really important, especially in the early stages of setting up a project or designing a product. It's really important to have access to quality and regulatory and know-how, either in-house or through councils, consultations with external experts, as it will probably can filter out projects that are going to be successful from projects that might be failing later on, because you will end up having to face costs that you cannot bear if you, for example, want to make claims, as Jess was saying.
So another question that's come up, well, Jess, you mentioned how a lot of products may be aimed at the consumer. but a lot of products in terms of AI are often also aimed at the healthcare professional. So a tool supporting a doctor to interpret an X-ray or something. The NICE evidence standards framework, which initially excluded any reference, what explicitly said we're not covering AI, basically says that tools aimed at doctors are the lowest risk. But is that true? What sort of evaluation do we need for a product that's going to be used by doctors in terms of diagnosis or in terms of making prognostic predictions?
Yeah, so the paper that and the framework that Cass and I have been working on is explicitly about AI tools that are used in clinical care settings. It's not necessarily about the consumer facing stuff. I don't think they are the lowest risk tools available. I think there's a risk mitigation factor because you've got a human in the loop. And you have potentially a human in the loop who can notice if there's a problem. That's caveated by the fact that you also can fall foul of this risk of automation bias, which is effectively the idea that the computer is always right. And so if I see something come back from a computer, I'm not going to question it because it's more stable, it's more reliable than me as a human who might have really low blood sugar, etc., etc. And we also know that clinicians fall foul of alert fatigue. So they're being notified about stuff all the time. And one of the ways in which these things are often deployed is through pop-ups in clinical systems. So have you thought about this? Have you thought about that? Have you thought about this? I think there's a need to also be looking and monitoring at the effectiveness of those types of interventions. And so this is really why I was talking about before the need to have multi-centered trials or multi-centered test sites, really, to avoid using the world trial for the purposes that we have already discussed, to look at that interaction element. And one of the things that we actually put explicitly in our paper is, and in our framework, is this idea that you should also be measuring the HCI element, so the human computer interaction element. I could have a on paper quantifiable, really well working algorithm that is really high specificity, really high sensitivity, working super well. As soon as there's a clinician or a human involved, it just goes haywire because it doesn't know how to deal with the unpredictable human. This is the same problem that we have with automatic cars. We know how to make automatic cars run on a road that has no stupid human drivers on them. We don't know how to do it with a stupid human driver and a machine at the same time. And so you've got to factor that in. But there's still a scale of risk. We've had clinical decision support software in primary care and secondary care since about 1980. This is not something that's brand new. The techniques that we're using to generate the insight is new. But that's another reason why I think it's potentially on the lower level of the risk.
There was another question here that follows, I think, very nicely from that one, which I'm going to address to Jean, who I realise is the chair, not the panel. But do you think that the approach to potential integration of new product into existing healthcare service needs to be factored into the design of the evaluation?
Yes, and you know I'm going to say that as an implementation researcher who, as Jess says, looks at human-computer interaction. In these series, we've spoken about a lot about user design, and I think whatever the intervention is, it's where it sits within a context. So I think Jess's point about how an intervention would work in multiple contexts is really important. And actually, very often the technique of observational research can be easily overlooked in evaluation, but it's really important. Talking to the users. We've spoken a lot as well in digital health about co-design early on. So I think we have to work with clinicians and patients and developers around the co-design bit, because that will later help implementation. And then when you're rolling out these digital interventions, you need the service evaluation or the implementation studies, normally across multiple sites, to pick up on variations in implementation. And often something we we see is that implementation effort is not always accounted for. So the training, the resource, the burden of change it might put on people in terms of their workflow processes, all of these things do need to be evaluated, because if you do it well, you get a smoother implementation journey. And if it's not done well, those human and process elements can really mean you don't get traction with a product, even if it's very good. I'm not sure if does that answer the question, Henry?
I think it does. We've got 5 minutes left, so maybe time for one more question. Let me read this out verbatim. I recently received a message on a family WhatsApp saying something along the lines of, the NHS are using our data, let your GP know to opt out. Do we need to do more public education platforms to get the public on board?
So presumably that's in response to the general practice data for planning and for pandemic planning and response, which is the data set that NHS Digital want to create, although it has now been delayed if you want more time to opt out. But I suppose there are a few things here. Yes, I think we do need to tell the public more. But I think it needs to be done in a strategic way. So I think there's lots and lots and lots of, whenever you do a research project, there's lots of like, hey, go out and ask people, do you trust me if I use your data? And you see lots of things that come up from, whether it be Ipsos Mori or YouGov, and it will say, do I trust the NHS to have access to my data? Do I trust the government to have access to my data? That's really very surface level. What we don't do very well at the moment is explain to the public how we go from, I'm sat talking to my GP about the fact that I have a headache. How does that get translated into my medical record, for that medical record to then be accessed by researchers or indeed the NHS itself for research purposes? And in particular, what we don't articulate very well is the fact that in order to do research on unhealthy people, we also have to have healthy people in the mix. So by and large, when you ask these questions to people, they will say, yes, I'm very happy for my data to be used for research, because people have this idea in their head, if I've got cancer, I want to also help other people be saved from cancer by enabling to use my records. What they don't necessarily understand and accept is that you also have to use that data for planning of services. So if I'm going to use the same cancer example, in order to evaluate how a cancer service is working, I also need to know how well unhealthy people are doing compared to the healthy people in that particular area. Or are there more cases of breast cancer in this region versus there are in that region? And that conversation doesn't happen very well. And we also don't ask bigger strategic questions of the public. For example, if you have opted out, what might make you feel differently? So what could we do? We could do differently. And that makes it hard to work out how do you change the trust level. So the one of the problems you have right now with the NHS Digital one is because it hasn't necessarily been very clear about what the governance arrangements are. And so to be clear, I'm very much in favour of the NHS having access to population level data sets. It needs them in order to continue to provide free at the point of care for its patients. I do think it needs to be clearer about the governance arrangements and how that data is being protected, and we should have more strategic conversations with patients about why it's important that go beyond, do you trust me?
Thank you. I'm aware of time. And we are, you've been amazing contributions, and thank you very much to Henry. So one thing to flag is we have another webinar coming up, which is going to think about those who use evidence. So there's a website link if you want to find out about our next webinars, and we've got another one in the details aren't up yet, but we will have another one on regulation coming up. I just want to take this opportunity to thank our panelists. These are difficult questions. It's very hard to summarize a discussion today, but I think quality data, public engagement about the use of data, partnership, And also you've heard about some new services and advisory services coming on board are really key. So please follow us with the hashtag. This recording will be put on YouTube. Please share it across your networks to those who you think will find it useful to engage with. And just final thanks to Cassandra, Carmelo and Jessica and Henry for co-chairing today. Thank you very much.